Good morning, everyone. We're going to get started. My name is Laura Roth. I am a research coordinator at the Medical College of Wisconsin and Children's Wisconsin in, you guessed it, Milwaukee, Wisconsin. I'm here with Alex Wilson, research manager for National Jewish Health in Denver, Colorado. And we have the privilege to kind of lead you along today's workshop titled Best Practice and Innovative Approaches to Clinical Research. And we have no relationships to disclose. So today's educational objectives are to describe best practices or innovative approaches to clinical research, to explain the importance of research awareness and engagement, and to identify at least one quality improvement project that you can implement at your site over the next year. And we're going to take this time to kind of encourage everyone in this room to work on a QI project in this next year and submit an abstract. And actually, the abstract doesn't even have to be a QI project. If you've done something in the last year, or you're working on something that's helping your site, submit an abstract. There's someone else in this room that is probably going through the same thing you are, and your abstract could help them. Anything you want to add to that, Alex? About submitting, okay. So submit an abstract. If you have any questions about how to do it, like I'm happy to answer questions. I've done it, I'm sure Alex is too. It would be really nice to go into the poster hall and just have a whole aisle of clinical research posters. So anyways, back to the workshop. This workshop includes abstracts that highlight unique clinical research strategies and methods for study teams. This session includes discussions around effective meetings, ways to understand potential participants' trust in clinical researchers, and improving accuracy of CFSmartReports via data entry. There are also 2 real-world studies reviewed that use alternate strategies for research in a world of remote visits and telehealth.
Okay, you can all hear me, yes, okay. I would like to introduce Tiffany McCrabb. Tiffany is a nurse practitioner in the Pediatric Pulmonary and CF Center at the University of Oklahoma Health Sciences Center and Oklahoma Children's Hospital in Oklahoma City. She has been in practice as a family nurse practitioner and asthma educator since 2005, championing asthma education and coordinating asthma educator training. She filled in for CF providers and served as a sub-I until assuming a leadership role for the CF research team in 2020. In 2021, she stepped in as the adult CF program coordinator, in addition to maintaining her research duties to fill in vacant gaps. She is committed to providing compassionate, patient-first, guideline-consistent care. Tiffany will discuss a quality improvement project her team worked on to reduce errors in registry, data entry, and therefore SmartReports patient summaries. Thank you, Tiffany.
Hello. First off, thank you so much to Laura and Alex for selecting our abstracts so we can tell you a little bit about what we've been working on at the University of Oklahoma. Now, if I can get the slides to advance, that would be good. Here. Oh, perfect. Thank you so much. Okay.
And you might be able to do it. Very good.
Oh, okay, great. So I don't have any disclosures related to this presentation. I'm going to tell you a little bit about how we made our CFSmartReports even smarter. Historically, our site hadn't really utilized our smart reports like patient reports for any pre-visit planning or anything like that, primarily because we found them to be wildly inaccurate. And that was primarily because data entry into Port CF was pretty delayed at our site. So I'm going to tell you a little story about how we got it up to date and made it more accurate and more useful for our team. In the spring of 2020, our research team assumed responsibility for data entry into Port CF And remote work during the pandemic facilitated real-time data entry. I know a lot of research coordinators found themselves at home at the beginning of the pandemic, and this is definitely something that was able to keep our team busy and make wild improvements to our registry data entry. Once our registry was up to date, we started printing and trying to utilize those CFSmartReports for pre-visit planning and that kind of thing. But we still noted errors, and it was really frustrating to us. As research coordinators, we're really nitpicky about things. We really like things to be accurate. When it's not accurate or correct, we're like, why is that not correct? And that's what really kind of prompted us to start keeping track of that. Our pediatric providers were really committed to using those smart reports to give to patients, to discuss their care with them. So we really wanted to be able to provide good, useful reports. Our PA, Janice Lynn, especially was like, other teams are using these smart reports. Why can't we use them? So that's really what motivated us. So we began tracking those errors and trying to get to the bottom of why we were continuing to have errors, even though our data entry was up to date. The other thing we did was we ran some population management reports and identified more errors that way. And about a year after the research team took over data entry, the 2 research coordinators were named as our registry coordinators as well. That gave us really some ownership over it. It also made them even harder on themselves about wanting to know that the data that they were putting in was correct. As research coordinators, we're used to having monitors look at our data and query us. And it was really frustrating, like, nobody's looking at this. We're the only ones that is looking at this. So we started printing the short summaries, and identifying, really rudimentary way, we just circled them. You can see just like, oh, that looks weird. This is a pretty good example of one that's like to the naked eye, there's something wrong there. How did that height percentile drop so rapidly? How did this kiddo shrink really quickly? And it let us know. And so we didn't do anything super fancy other than I circled it. And I looked it up in our electronic health record, and I was like, oh, what happened was, and we just jotted down at the bottom what the error was. And in this case, inches was entered into the registry as centimeters, and the registry coordinator corrected that, reprinted the report. We discovered that if you make a correction, you can't reprint the report until the next day after 7 a.m. So then we would reprint the report. That way it was now an accurate report that could be useful to the team. Here's another example of one that just there on those like nutritional status, the graphs, those kind of things, those errors really stick out to you pretty easily. Let's see if I can make this. Nah, it's okay. You can see there the purple on the bottom that shot up there. We noted that was where a weight was entered instead of height, and that was then corrected and reprinted. As we went along, we got even more picky, looking along the left-hand column at, why does it say that they haven't seen, the pharmacist for 2 years? We have a pharmacist. She sees our patients at least once a year and writes a note. Why is that not correct? So that's when we started running population management reports, especially those reports that are not seen by reports. And we started comparing that to our medical record as well to identify more errors. I probably got a little ahead of myself talking ahead of some of these. So those smart reports with errors were collected. We compiled that into an Excel spreadsheet for tracking. We sorted and reviewed it for trends. It wasn't fancy, guys. I just typed them in and then sorted a column. It wasn't super high tech. But we did use some key driver diagrams and PDSA, plan, do, study, act cycles to guide our improvement process. Here's an example of one of our PDSA cycles that I already mentioned. We wanted to compare the population management not seen by reports to the EHR encounters. We found missing encounters we found a lot more than we thought we were going to find. And so therefore, the number of errors, we were tracking our errors every month. So the number of our errors, when we ran population management reports, all of a sudden our error number shot up, which we're like, darn, that's not what we wanted it to happen. But as time went on, then we decided to go ahead and run those population management reports more frequently so that we could catch missing data. Overall, through the project, we found 182 errors over 2 years for the pediatric program. We started with the PEDS program just because our PEDS providers, Dr. Meddy and Janice Lynn especially, were really committed to using it for clinical care. Our pediatric CF coordinator, Jen, also really wanted to be able to use it for pre-visit planning. So that's why we started first with the pediatric program. But after the first year, we expanded that into the adult program as well to help the adult coordinator with pre-visit planning. They haven't started handing it out to patients as of yet, but in that first year with the adult program, we identified 79 errors. We had a lot of theories as to where the errors were coming from. Initially, we thought a lot of the heights and weights and those kind of errors might have been in our electronic health record, like perhaps when the patient was checked in, did the medical assistant accidentally transpose the numbers, put height or weight, and that really wasn't the case at all. It was overwhelmingly the data entry error was data entry into port CF. So we realized this is our problem. This is us. The primary error type that we found was missing data by far. It was missing data. We also had some incorrect data and some incomplete data. The most common missing data type was an encounter. And that could be an encounter with any member of the multidisciplinary team, or even like a nurse visit or hospitalization. Those are the encounters were by far the most common thing we found. We also found missing screenings and chest x-rays, just a few medications, complications, one little micro error that was missing. We divided it out to see those missing encounters, what were the most common ones to be missing, to help kind of guide us to how do we go about fixing it, where's the source of those errors, and how do we capture it. As far as incorrect data, by far biometrics like height, weight was the most common error that we found. The others were far less frequent, but complications, medications, micro, PFT values, some other incorrect data we found as well. So for those biometric measurements, just a totally incorrect weight was the most common thing, followed by height and weight being transposed, followed by height being just entered incorrectly. And then we get into all the other transposition of things like pounds per kilograms, inches and centimeters being transposed as well. So through this process, we had quite a few lessons learned. We discovered that with the registry, data entry being up to date, it's really easy to miss encounters that are entered into our electronic health record later. Some of our multidisciplinary team members might document some things on paper or keep notes and then go into the EHR later to put their encounter in. And if our registry team had already put that visit in, they've moved on to the next patient. And then when it comes time for that patient to return 3 months later for their next visit, that encounter might not have been captured with the previous visit. We discovered that our EHR, or at least our old EHR, listed weight first, followed by height, and Port CF has it in the opposite direction, which is why we had so many transposition values. Our new EHR also now has birth weight right next to the current weight, and that was a source of a few errors. We learned that biometrics are very easy to transpose in various ways. We learned that preliminary microbiology reports can change. We learned that some data is only captured on the annual review form, and it'll be missing from reports until that is entered. So what did we do about it? Now, our multidisciplinary team members are opening encounters in our electronic health record, even if they're not finished with their documentation for it, they at least open a note to signal to the registry team that an encounter has occurred so that it can be captured with that other clinical encounter. Registry coordinators, just by means of tracking, are certainly much more aware of the risk of transposing biometric measurements and more careful in double checking as they're doing data entry. Our registry coordinators are waiting until the very final micro report to enter data into Port CF. And we started opening annual reviews as soon as a reportable event occurred in the year, rather than waiting to the year end. That way that data could appear on the patient reports. So this is a error trend over the project period. You'll see there the darker line is the pediatric program and the yellow is the adult program. That first big spike in the pediatric program is when we ran population management reports and found all of those missing encounters from the multidisciplinary team members. But overall, our trend declined until about a year later, we ran population management reports again, and we found a whole bunch more, but not as many as we did the first time. And our adult registry coordinator had the benefit of learning all of the common error types that were occurring in the pediatric program, so we're able to apply that learning to the adult program as well, and we were able to reduce those errors over the time in that second year of the project. So because of this project, we've had some process changes. Our patient short summary reports are printed and reviewed electronically a few days ahead of any CF clinic for any scheduled patient. Errors that are noted are corrected, and then the reports are either reprinted or sent electronically. The reports are provided to the CF coordinator and the team for pre-visit planning. And for the pediatric program, those reports are provided to the patient and family by the provider during their visit. They explain the report to patients. They use it when they're discussing things like our nutritional status has been declining. We need to think about a G-tube, those kinds of discussions. They found those charts to be helpful in that way. The real heroes of this project is our registry coordinators, who've been really successful at keeping our data entry up to date in real time for the last few years, on top of their other clinical trial coordinating that they're responsible for. So Kim and Ashley are our coordinators. This is the rest of our research team, including Dr. Meddy, and our sub-investigators, Dr. Palais and Janice Lynn, and myself. This is our full team, and I would tell you if you're thinking about doing QI, which you should be, everybody should be thinking about doing QI, you just have to be aware that it's easy to get your feelings hurt when you're looking at errors, but really our goal, we really tried to focus on what we want is to have useful reports that our providers and our patients can really utilize and that can be helpful. And so we were pretty hard on ourselves, and we still are pretty hard on ourselves, trying to just make the reports the best they can be. And it's really helped us as a research team as well, because now we know that what prints on those reports as far as they may be eligible for a study, we know that's accurate. And when we're running smart reports for recruitment purposes, we know that that's accurate as well. So if you're thinking about doing a QI project, just do it. If Tiffany and the team in Oklahoma can do it, you can do it too. This is us on Halloween. Our clinic manager really is good to do themed outfits. And we love, you can tell we love working in a children's hospital because we get to be silly and fun at work. So we love that. Thanks.
Thank you. I just want to thank you for encouraging everybody to do QI as well. And also thank you as the registry coordinator at our site. I always appreciate hearing stuff about data entry at Port CF because it's a lot and we all have to do it. And so I appreciate that. So if you have any questions, you can type them in the app or there. Please go to a microphone. Looks like over there. Is that the only microphone? For Tiffany, anybody have questions? I do have a couple questions.
Sure.
So now that team members, so you review who saw them, like respiratory therapists, that you review it, the registry coordinators review it, or do the team members review that list?
As far as for the population management,
Yeah.
like not seen by reports.
Yeah, that's big, yeah.
So I'll tell you a big lesson that I learned. Early on, I printed those off and I handed them out to the interdisciplinary team members. And there was a lot of errors in those reports. I mean, as you saw. And what I found was that there was a lot of hurt feelings by that. Because when somebody gets a list that says, these are all the patients that you didn't see this year, they're like, I did see those patients. And what I intended was, if any of these are like striking you as, why is that on the list? Like, it was really for the intention of help us find our errors. But unfortunately, some of our team members took it as, here's a list of where you messed up. So I would say, don't do it that way. The first time, that's what we did. It did not go over well. But what I did get back was a lot of angry notes. I did see them on this day. And so we fixed all that. And then the next time, I reviewed it myself. And only provided the list once I had confirmed that we really didn't have anything in our electronic health record to say that that particular person had. And then it's useful to them because they know I've double checked it and we really didn't find a note. And then that allows those multidisciplinary team members to know who they need to focus on before the end of the year, before the cutoff of, we really need to get an encounter in there.
So now that they entered in themselves, that's what you said, correct? That they go in and enter that, like they open the encounter and say that they saw a patient.
So yes,
right?
after.
Do they still review then, like at some point, like quarterly, or that they, like a list of patients they've seen?
Yes. Well, they can have it if they want it. I would tell you that. They can have that report if they're interested in that information. I have run it still and reviewed it myself so that we know that we have all of the data that's there. But that was a big lesson learned. Don't hurt your team members' feelings by giving them a list of people that they haven't seen this year.
Any questions out there? Any questions in there? I do have one more question for you. Okay. So, I just wrote notes, so I have to think about how I'm going to word this. Since now that the research coordinators are doing data entry and you're using the SmartReports, like for clinical care, basically, right? Have you looked to see if your your data entry is more timely now?
It's a lot more. It's a lot more timely now. Yes. Great. Yes. Good. A lot more timely. Yes.
Any questions for me?
One other really nice thing was there used to always be like a rush during the holidays. Like everybody's like, oh, I got to work overtime, get in here and do some data entry. And it's really nice when it doesn't matter. We're all caught up. We've been caught up. I mean, I think the most we've been, and maybe just sometimes when somebody has been sick or we've had some family members who've been sick and that kind of thing, I think the most we've ever been is maybe 2 weeks behind, like literally 2 weeks behind. Otherwise, really everything is as current as it possibly can be. And we're the ones saying, where's this micro report? Why hasn't the lab reported off on this? So we're waiting on that report still, so.
And then your annual reviews are pretty much almost all done by the time that.
Yes, the annual reviews are, well, yeah, you're not doing a rush for annual reviews at the end of the year either. Those are all pretty much done, yeah. This is a whole separate project, but we also do, at the end of the year, we do a little survey just to catch anything else that's on the annual review that we need.
Okay. Great.
For those of you that are standing, there are several chairs over here. If anybody wants to come sit down, there's a whole bunch up front. Everybody's favorite place to sit. But yeah, and then also thank you very much, Tiffany. It really seems like this has resulted in a process change, which is certainly a goal of quality improvement. So well done.
Thanks. Thanks for that.
Our next speaker is Justin Crow. Justin is a current graduate. You can come on up. Justin is a current graduate research assistant in the STED. I said that right? STED Family Department of Pediatrics, Pulmonary Division, at the University of Iowa. He has worked in the department since 2020, formerly as an undergraduate and full-time research assistant. Justin obtained his Bachelor of Science in Public Health at the University of Iowa in 2022 and is currently working towards his Master's of Science degree in epidemiology to further his career in research and academia.
Hi there. Today I'm going to talk to you about a little project that I worked on not this past summer, but the summer before for my experiential learning project for graduation at the College of Public Health. It's titled Building Trust in Cystic Fibrosis Research, the Use of a Hands-on Conversation to Gauge Trust in Researchers Performing Phase 1 Clinical Trials. And here's my disclosures. I don't have any. An overview of what I'll be talking about. First, I'll talk about the background and objectives of kind of how I came upon this little project. We'll talk about the project itself, some of the findings that came out of it, the limitations that I encountered throughout, and then what I kind of hope for in the future. So the reason I kind of came around to this idea was, as we all know, there's approximately 10% of the CF population that's not responsive to highly effective modulator therapies. Those people with rare mutations, and then eligible people who do not tolerate. We know that there's a lot of current research focused on mRNA and genetic therapies, and that those phase 1 trials are ongoing. And so in order to get these people a therapy that works for them, we need to build a culture of inclusivity and trust. And so that's kind of something I wanted to build into the process of meeting people and talking to them about being a part of research. So the questions and pictures I'm going to talk to you about were adapted from a similar project aimed at the understanding of trust and vulnerability of these people with CF and their care. And this was originally created by a key stakeholder group and Stacy Van Gorp, and the group was See What I Mean. They're a consulting group that kind of works to help build qualitative research methods and to kind of do what I'm going to talk to you about here soon. So the pictures were selected from the project. They didn't have any predetermined meaning at all. Rather, they were just selected from the parent. They were the most selected from that parent project. So now I'll kind of talk to you about how I went through the project. So everybody I talked to was from the adult patient group at the CF Care Center at the University of Iowa. So what I kind of did was I went into the room. We see everybody that comes to the clinics, and I kind of talked to them about my project. I discussed with them what a phase 1 trial was in case they weren't entirely sure. And then I also talked about other therapies that are out there that they may know of, to kind of relate that back to that. All of those have also went through these phase 1 trials as well. Then I handed out 8 laminated cards with pictures, and then I kind of gave them 2 kind of statement questions. So the first statement was, imagine you've been invited to participate in a phase 1 clinical trial. Look at the pictures below and pick the one that represents how participating in this trial would make you feel and explain why this picture represents that feeling. And then I kind of just gave them a moment to sit in silence and look through all of the pictures that they had in their hand. Then after we discussed that question, we went on to the next one, which was with the same set of pictures. And it was, now I would like you to look at the pictures again and pick which one represents how you would want your relationship with the research team to be if you did join a phase 1 trial, and explain how this picture represents that relationship. Then again, sat in silence, and then we discussed. I think a big part of this project was also in the beginning, just kind of figuring out how to interact with the participants as well. There at the beginning, I had learned that to make the conversation a little more adaptable to the situation and making it a little more inclusive, that I shouldn't be reading directly from a note sheet or something like that to kind of ask them those questions. So then I have a person in the back of the room that was just taking simple notes, and so that I was able to keep my eyes on the participant and make sure that they felt heard when we were discussing those statement questions. And then they just simply took some notes and then jotted down which picture they selected. So over that summer, I was able to interact with 31 people. I had 14 males, 17 females, and then of that, there were 29 white non-Hispanic, and then only 2 Hispanic people. So here you can kind of see some of the pictures from the statements that were selected. I did have on my first question, somebody pick several pictures. They thought that not just one represented how that would make them feel. So I thought that was kind of interesting. And then I had some that would say, you know, they didn't think any picture represented how they felt. So for that first statement, some of the key things that kind of went along with those pictures were from the balloons. A lot of people thought it was that this kind of research meant celebration, and they were going to go with the flow, sort of. Then next we have that crashing wave on a lighthouse. A lot of them said that it represented kind of the unknown and not knowing, you know, what was going to happen during this phase 1 trial. Then we had a little fireplace scene. A lot of the people that selected this had been doing research before or were in some other form of a study with us at the university. And so a lot of them said that they felt already comfortable doing things, or that they would be relaxed, but because it was a phase 1 trial, they still felt they would, you know, not have that information that would make them more comfortable. And then we also had this crazy roads and intersection scene, and a lot of people thought that would, you know, being in something like this would add to their already busy lifestyle, and that they already have a lot going on, so maybe it just wasn't for them. So next, we had a little mountain scene. Again, we talked, a lot of them said that, you know, being a part of research made them peaceful, knowing that they were doing something for the greater good. We have a couple of our participants that we see all of the time or in many of our little studies, and so they said it reminded them of home. We also had the open doors scene, that they're very open to being a part of research and they want to advance the therapies that are out there for people with CF. And then we also had kind of a rocket launch scene. People thought it was excitement, reaching some new horizons. And then we also had seed growth, possibility of a growth improvement for people with CF, and then that there's a real potential for progress. For my second statement, kind of talking about the relationship they would want with our group, they really thought that it should be happy and that it should cheer them up. With that kind of what many thought was kind of a more scary or scene, they thought maybe that lighthouse kind of gave direction as to where they should go. So as a research coordinator or part of the team, that you should be kind of guiding them through that process. With that fireplace scene, we also, you know, saw a typical, you know, it should be a comforting, relaxed atmosphere where you're able to ask questions and you can be vulnerable with them. And then a lot of them said for that road scene that it was kind of, you know, they may not know what's going on, but they really hope that the research team does, and that that we're kind of helping them, which, you know, with the phase 1 trial, we have, you know, limited knowledge as to what could happen, but, you know, we're really going to try our best. With that mountain scene, we also saw, that the relationship should be peaceful, calm. You need to be open and communicable with those open doors. With that rocket launch, you should have, it should be excitement, exploration, and advancement, lots of communication along the way. With the seed growth, together over time, adapting to each other, becoming more personal. And then also, growth and understanding of the study and the outcomes that are possible. So my findings, I really think that the patient answers for question 1 indicate that there is unknown risks of the study are of concern, and I think that's something that we need to be upfront about with them and comfort them and guide them through the whole process as we move through the study. But it also indicates excitement for research. And that they're ready to be a part of it, and that it's something they're willing to do. For the second one, it largely expressed a need for a caring relationship. We need to be there for them, and then, in turn, maybe they'll be there for us, and we can make something of that and, maybe even increase the return of participation in future studies. And I really do think that by adapting to the needs of our participants emotionally as well, we can foster a trusting relationship and build that culture of inclusivity and trust. And so there at the bottom, I kind of broke apart into 3 things that we should remember as we're going through and speaking. And with subjects and participants, we should be caring. It takes a competent researcher, somebody that really knows what they're doing. And that, we need to individualize the care that we provide through them throughout it. So some of the limitations I encountered, just because of our geographic location in Iowa City, Iowa, we didn't really have a diverse population to really speak with, and I was limited to the time I could do the project that summer. And so I tried to reach as many people as possible, and that's just how it was. Due to time constraints, I only got to speak to 31 people. I would love to speak with everybody who comes to our center, but that was just not possible. And then, at the university, nearly 90% of all of our patients are a part of some study of some sort, whether it be we just collect a sample for them for, a biobank type study, observational. We're constantly seeing them. So our coordinators are always in the room with them every time they come. And we're always interacting with them. So I couldn't really get anybody that I'd never seen or met before, which that's okay though too. So I guess it means we're doing something right. So for the future of the project, I want to implement this into, I never really got to use it as we consent a person or get to know them for the first time. So I think that's something I'd like to see. Further development of our questions, find ways to maybe tweak them, make them a little different, or change them up completely and use them in different ways. I think it's also important that we can use this for not just phase 1 trials. We can do it with whatever we want, phase 2, phase 3, or just even to get to know the person if it's their first time coming to the care center. I also think that it would be interesting to speak with pediatric participants and then with their families to kind of see what they think and compare those ideas. So, special thanks to Stacy Van Gorp and See What I Mean. That group really kind of gave me this this kind of stepping stone to build something that was from and take it and adapt to a research setting. Mary Tressie, my supervisor, thank you so much for allowing me to kind of go through the clinics and kind of help me guided me through this project. And then Catherine Sager, my loyal note taker in the back of the room. Without her, it wouldn't have worked at all. And then the providers of the University of Iowa CF Adult Clinic for allowing me to take up a little extra time in their busy day. Now I have time for some questions and answers.
Thank you so much. That is a very unique project, and I think a really interesting way of reaching out to potential participants and opening the door to that research conversation. I do have a question for you about how you envision this project might impact how you approach potential research participants in the future, and then how you might use this information once people are enrolled to keep them enrolled.
I think really how I would use it would probably be when we are looking for subjects for a study, and then we kind of, instead of just walking in and barging in and telling them all about the study and who we are and what we do, maybe just sit down and talk to them and be vulnerable with them and just talk about and make a conversation that's a little more inclusive instead of just putting a bunch of things out about a study. And then I think, us knowing this information about the person throughout the study and then into the future, it'll make sure that we adapt to them, that we know what their needs are, and that by doing that, maybe they'll return to us again and want to be in more studies.
Great, thank you. I think that of all the conversations we've heard in the last several TDN meetings, that is so important, is allowing that engagement and conversation and vulnerability for the participant to ask questions. Again, if you have questions that you want to ask live, you can go to the microphone. And lessons learned from the last presentation, there's a little bit of a delay up here, so I apologize for someone that had questions that we didn't get to, but we do have one from the audience in the app. You mentioned that 90% of patients take part in research studies in some form. So is this other studies outside of the registry?
Yeah, there are a few, I believe. Off the top of my head, I'm not 100% sure. But I think just being a part of research and being with us, I think that's really all that matters. Mm-hmm.
So we have 90% of our patients that participate in a simple study, one of our pediatric.
Yeah. Yep. Yeah. So it's kind of a homegrown study that we kind of go in and we get micro samples along with their clinical one, and we kind of bank them.
Gotcha. So the answer from the crowd, this is recorded, so I will repeat this. There was an SA study, that Staph aureus study that the pediatric population could participate in.
Yeah. And nearly everybody is a part of it, so.
Good. Okay. Thank you very much.
Okay. I just had one comment. If you do this in peds, can you publish that? Because I'd love to hear what the kids have to say. Because as someone who spends 8 hours in a room with a kid,
it'll get very creative. I tell them
I'm going to write this all down, and when they're 18 and transition adult care, they're going to have a whole book of all the fun things they've said.
Yeah, for sure.
Okay. I will introduce our next speaker, who is Lisa Bendy, the research manager for the Pediatric Pulmonology, Allergy, and Sleep Medicine Division at Indiana University in Indianapolis. She works at Riley Hospital for Children and has been on the research team since 2007. Lisa serves as the lead TDN RC for both the peds and adult teams at our site. She's the lead RC for both the STOP Peds and Hero 2 studies, is an RC mentor, serves on the TDN Regional Co-op for the Central Ohio and Kentucky region. And she'll be talking with us today about the Hero 2 study, namely getting feedback from RCs and PIs about the feasibility of conducting real-world research from people with CF. Welcome, Lisa.
Thanks. Do I use this or just the keyboard?
I click on it.
Oh, okay. Yeah, you can. This one? Okay. All right. Good morning, everyone. So today I'm going to talk a little bit about the feasibility of conducting our real-world protocol, the Hero 2 study. I have no relationships to disclose. So thinking about traditional clinical trial versus real-world research, I'm going to have to put my glasses on. We think about the study type, randomization, duration, visits, outcomes, and data collected and how that is done. In a randomized clinical trial, the traditional trials that we're used to conducting, the trial decides who and when things happen based on the protocol. Minimally, study duration lasts 10 weeks, up to multiple years at times. Study visits are required. Data is collected at those study visits, and a primary outcome is typically lung function. In an observational clinical trial, there is no changes to what the patient takes. The clinical therapies remain the same. The studies typically last a longer duration. Study visits are required. Data is collected during those study visits, and our primary outcomes or end outcomes can be multiple different things. So, in real-world research, it is an observational study that we conducted for HERO2. It lasted for 12 months. There were no changes that were prescribed to the patients, but it was more collecting and looking at what the patients did based on how they felt once they started their ETI therapy. We did look at lung function as a primary outcome, and that was based on information that was collected from patients and also what we paired their information from with the CF patient registry data. So a model of real-world research, you look at study is designed with input from our patients with CF and their caregivers. What do they want to get out of this research? What kind of information do they think is helpful and beneficial from their perspective? The research can occur in real time, can also occur during clinical care. It can be more inclusive. We can reach out and have more diverse patient and study participation in study populations. Data is collected from their medical records. It's also the information that they input and provide to us via the app that we had with HERO2. And the outcomes are very important with patients with CF. What's really happening with them? What does their daily lives look like? How does this impact them? So what we need to consider is, instead of clinical trials versus real-world research, maybe we should start looking at clinical trials plus real-world research. Real-time information that can help, how does this clinical trial impact me, and how can this complement this clinical trial that I'm participating in? How does this treatment work for me? For each individuals, it can be a different experience, and how can that really impact their lives and under their normal daily experiences and circumstances? So a little bit just to review the HERO2 study. It was a study that we did to assess the impact of ETI therapy on changes in their chronic CF treatment regimens in people with CF. The specific aims were to determine the proportion of clinical features of those patients taking the ETI who make changes to their chronic daily therapies. These weren't necessarily changes, again, prescribed by their physicians or their care team. It was their choice how they chose to change their daily therapies. There was also an assessment of the relationship between the changes in their CDTs and changes in their pulmonary outcomes, such as their lung function, pulmonary exacerbations, and identify clinical features associated with stable pulmonary outcomes following those changes that they made. HERO2 was 12 months. It was prospective, observational, cohort study, again, looking at those changes that people with cystic fibrosis chose to make after starting ETI. They had to be 12 years or older. They enrolled into the study through an app called Folia. They could enroll through that app independently. They already were a Folia user. They heard about or knew about the study based on their use of the app. They could also be referred by a clinical site, or they could also be recruited by a clinical site. Participants used the app to track their daily CDT use and symptoms, to complete review of that CDT use, and validated patient-reported outcome questionnaires. There were no study research visits. So the purpose of the study was to collect data from the sites that conducted the study or participated in this study to see how the PIs and the RCs felt this real-world research project went. The feedback for the feasibility was from the perspective of the different coordinators and principal investigators at those different sites, referral and recruitment. Referral sites simply had a flyer that they handed out to the patient. There was minimal engagement about what the study They didn't help them consent or anything like that. Whereas recruitment sites were a little more involved in that recruitment. They could speak to the participants a little bit more about the study, and they were actually asked to do check-in calls quarterly throughout the patient's participation, just to give support and keep them engaged in the project. It wasn't to do any kind of study data collection or anything like that. So in total, there was 155 individuals that received the survey to complete about the protocol conduct, 80 RCs and 75 PIs. And they were from recruitment sites and referral sites. There were more referral sites than recruitment sites. Of the recruitment sites, 17 sites actually had at least one subject enrolled. So there were some sites who actually did not have any participants that ended up enrolling in the project. Of the referral sites, 49 of them had at least one subject enrolled. The typical survey questionnaire was kind of like the ones we get at the end of study participation from TDN CFF. There was one question that was on a 5-point scale, 1 to 5, rating their experience from poor being 1 to excellent being 5. And then we had 13 other categories where they were allowed to give free text feedback comments, and comments that we looked at and collected from that were divided into what was considered a positive feedback comment, and then we had neutral, constructive, you may say negative comments, but again, neutral constructive comments. So looking at that information, we had 66 of 155 participating CF Center research staff complete that survey. That was about a 43% response rate. PIs were divided up versus the RCs, so 25 of 75 PIs completed it, and 41 of 80 RCs completed the survey. So overall, 70% of the survey respondents, those 66 people, 46 of 66, rated their experience as good or excellent, completing or interacting and doing the Hero 2 project. 29 of 39 referral site participants rated as good or excellent, 74%, and then the recruitment sites were a little bit lower at 63%, and we think this may have been due to some of the comments that we received in the free text about things like budget, contract, and things like that, since there was more engagement in that type of activity with the recruitment sites. 18 of 25 PIs that responded and 28 of 41 RCs that responded rated it as a good or excellent experience, so about even on that. And once we compiled all the comments across all the different categories for the free text entries, we had 140 of 191 comments that were in the positive category. So looking at this a little bit closer, again, survey respondents by role, PIs versus RC, we kind of went over that statistic already for the total, but breaking that down into the actual 66 that responded, 38% of those were study site PIs of the 66, and 62% were from research coordinators. And then looking again at recruitment versus referral sites, breaking it down a little bit further, of the 66 responses, 39 of 66 of the responders were from a referral site, and 27 of 66 responders were from a recruitment site. This is just looking a little bit more closely at the numbers that responded as good or excellent overall, rating their experience. So a total of 46 of the individuals. Looking at referral versus recruitment site. So in here we had a poor rating of 2. We assumed that maybe those individuals were from the same site, but what can we do better? That is one of the things we need to take away from this. It's disturbing, I'll say for me, when I see somebody rate something as poor, because I'm like, what could we have done? What could we have changed? What could we do better? And despite communication, multiple meetings and things like that, sometimes that's their valid feelings, that's how they felt. But we really do want to do better. We want to improve their experience, because that ultimately is going to improve their overall experience for their patients as well. So again, just looking at PI, a total 72% and RC 68% rating as good or excellent in the categories. So in conclusion, the category that we saw the most constructive, neutral comments from was, again, invoicing. So thinking about how can we do better communication with looking at CTAs, budgets, things like that, and just improving that process and making sure everyone's getting the information that they need. How can we better support them? And as we look at traditional study designs becoming increasingly less common, it will be critical for researchers to make use of efficient and accurate alternative designs. Overall, we feel the results of conducting the HERO2 study design from the perspective of the PIs and RCs was useful. It was a positive experience. Just working on, those that may have felt like the experience could have been a little bit better for them. So this design is important to facilitate finding necessary tools and study content for future real-world clinical trials in CF, and we want to improve this content and help conduct future clinical trials. So this is my poster with that information on it on 671, and we want to, just thank again the HERO2 community, our patient partners, Laura, Gunnar, and Jackie, and just everyone for their support for this important project. Thank you.
Thank you. We do have one question on here. How did you pick the Folia app to use? Do you think it affected rating from the participants?
The rating from the participants? From the RC's perspective? Well, actually, the study teams did not have access to the Folia app. It was only the participants that signed the consent and interacted with the Folia app. While they were given information about what the Folia app looked like, how they interacted with it, actual PIs and RCs didn't have to do anything. The patients themselves went into the Folia app. They signed the consent themselves in the Folia app. The sites did not have any access to that information. We would get the feedback from the Folia app, from the Folia team, to how they were doing as far as completing their surveys and things like that. But again, RCs and PIs didn't have to monitor any of that information or anything like that throughout the study.
Thank you. Did we address the question appropriately? I think so. Okay. And I have a question. In a world of where we are really encouraging referrals from other sites, how was the process for referring sites? And do you know if many of them at their institutions had to do engagement determinations for this, or anything extra that made the referral process more difficult?
Not that we were given feedback from sites when we did our, our update meetings and just feedback meetings with the sites, referral and recruitment. We had several of those different meetings throughout the study conduct just to keep people on the same page. Referral sites, I think it was kind of interesting and difficult in the beginning. McKenna Flory is the program manager under Dr. Brown over on the adult side, and she coordinated a lot of this and just guided the process for clinical trial agreements and budgets and things like that. In the beginning, she got fielded a lot of questions about how do we do this, how do we do this. It was very difficult for sites, I think, to think about, we don't have to do an IRB. We don't have to do this. Referral sites didn't have to do a contract agreement or budget either. Recruitment sites did, because again, they did a little bit of activity with contacting patients quarterly just to keep them engaged. Again, they weren't doing a study visit. They weren't conducting any questions or collecting data. They were just keeping patients engaged. So I think in the beginning, McKenna and I did several phone calls just to keep everybody on the same page. And even though we did, study seminars and things like that, there's still people have questions. So I think referral, it was just really odd for people to just be like, here's a flyer and hand it to a patient. It's like, that's all I have to do. That's not how we do research. That's not how we conduct ourselves. So I think, even as I started in our peds clinic, I was kind of like, I want to stand and talk to my patient because that's how I am. So it was kind of an odd transition.
It is an odd transition. I also think, too, that the clinical team can be really helpful in referring and handing that flyer because they're obviously the ones seeing.
Yeah, and we
versus
utilize
providing
that too. Yep.
Good.
Yeah, we were a recruiting site, and we had to go to our IRB, and they determined we were not engaged. So even the recruiting sites weren't engaged with in research for that one. So that was definitely a weird process. So my question, and this isn't really it's related to Hero. Did you notice a difference in compliance between the recruiting and referring sites? Because obviously they were getting, with the recruiting sites, they're getting phone calls and
Did I notice?
like a difference in compliance of doing the questionnaires and stuff?
So that data is still being compiled as far as what they engage with or not, but the monthly dashboard that was updated for us, you could see trends in some patients, whether it was based on a recruitment or referral site. I don't know that there was actually a difference between the referral versus recruitment sites. Feedback from recruitment sites, though, were the unfortunate kind of trend for you call somebody, they don't pick up the phone. So, and a kind of a golden rule is you try 3 times and then you're kind of done. But it's just interesting how we live in a world where people want to, I don't know if they even respond to text hardly anymore. So, but just making phone calls and things like that, but just trying to keep our patients engaged. Yeah, I think there potentially could be a difference there, but we don't know the full data set yet. So. All right. Thank you so much.
Okay, our next speaker is Jonathan Greenberg. Jonathan is a clinical research manager with the Division of Pulmonary Medicine at Boston Children's Hospital in Boston, Massachusetts. Jonathan has worked at Boston Children's since 2012, where he manages several observational and investigator-initiated research studies within the division. He has worked on a number of cystic fibrosis clinical trials as lead coordinator and has served as the program manager for the study management core of the Cystic Fibrosis Foundation's Success with Therapies Research Consortium since 2015. Jonathan.
All right. Actually, can I grab some water first? Just in case. Desert air. It's killing the throat. Right. Good morning, everyone. We're in the home stretch here, heading out to lunch soon, so thanks for sticking around for this. And thank you for inviting me to speak about our abstract. I'm going to talk to you this morning about our research coordinator perceptions of a coached home spirometry protocol, ongoing experiences with the outreach study. And I have no relationships to disclose. But I would like to acknowledge the co-authors with me on this abstract. So most of you are familiar with the outreach study led by the TDNCC. It's an ongoing, for those of you that aren't familiar with it, it's an ongoing observational trial looking to evaluate whether home spirometry could be used as an outcome measure for clinical trials among people with CF. There's strong rationale for remote endpoint collection, specifically in cystic fibrosis population. There's several reasons for this, but first, as the health of people with CF improves in the era of highly effective modulator therapy, patients may have less frequent CF clinic visits, to which research visits are often coupled. So there's also novel endpoints involving home monitoring may be necessary to fully capture treatment effects. Second, as members of a rare disease population, CF patients often live far from CF care centers, increasing the burden of research visits. Barriers to physical visits are also high for rural and lower socioeconomic status patients. So remote endpoint monitoring could improve access to trials for underrepresented populations. So the objective of this study is to assess the experiences of research coordinators conducting the outreach study with a focus on the feasibility, acceptability, and appropriateness of the protocol and any barriers to training and coaching participants in home spirometry. It's a prospective longitudinal study of CRCs who are conducting the outreach study. And there's also a subset of CRCs who will participate in a focus group, but that's not the focus of this presentation. So the study was reviewed and approved by our IRB at Boston Children's. And prior to site activation of outreach, CRCs went through a thorough training with lots of materials that were developed through co-production with CRCs and with people with CF to learn how to train participants and coach them in home spirometry. These materials included videos, written manuals, guides for the software and for the app. After a site was activated to begin the outreach study, I reached out to the CRCs who were trained and asked them to participate in an anonymous web-based survey study to capture their experiences working on the outreach study. So at the baseline survey, we collected demographic info, experiences with technology, and CRCs were also asked to assess the overall protocol, the overall outreach protocol, and their protocol-specific training using a validated measure scored 1 to 5, with higher scores indicating greater acceptability, appropriateness, and feasibility. And after the CRCs trained at least 2 participants on the outreach study, they were prompted to complete a second survey asking about their experiences training those participants, and again to assess the overall protocol, the overall outreach protocol, with the same validated measure used at baseline. So the CRCs were asked to assess the overall outreach protocol and their protocol-specific training using these measures, scored 1 to 5, with higher scores indicating greater acceptability, appropriateness, and feasibility. So here's the validated measure. And then on the left is an example of how we use the measures for the study. So in this example, I'm showing the acceptability of intervention measure. And the questions say, the outreach protocol meets my approval, the outreach protocol is appealing to me, I like the outreach protocol, and I welcome the outreach protocol. And as you can see, you can score it 1 through 5, completely disagree, disagree, neither agree nor disagree, agree, or completely agree. Here's the schedule of surveys. I already mentioned the baseline survey and the post-training survey, but for the midpoint survey, there are questions on CRC experiences after 3 to 6 months of training outreach participants on home spirometry. Questions like satisfaction with scheduling, training materials, et cetera. And we repeated the AIM, the IAM, and the FIM to assess the overall outreach protocol, and a new AIM, IAM, and FIM to assess scheduling, conducting virtual coaching sessions. And then the last survey is the end of study survey. And again, there's questions on the overall CRC experiences with the outreach study. We repeated the measures, the AIM, the IAM, and the FIM again to assess the overall outreach protocol, and a new AIM, IAM, and FIM to assess scheduling and conducting virtual coaching sessions throughout the study. I'm going to take a pause and just drink a little water real quick. All right, so I'm going to walk you through some of the demographic data from the baseline survey now. So there were 38 baseline surveys that were sent out to the CRCs, and 29 responded. So 26 respondents were female, so it's 90% of the respondents, and 2 were male, and 1 preferred not to answer. The average age was 41, with a standard deviation of about 12. And here's the self-reported background of the CRCs. So hopefully you can see, but 38 responded that they are CRCs. 31 responded that they were research coordinator nurses. 21 respond that they were nurses. 4 were CRC respiratory therapists, and 3 were respiratory therapists, and the last 3% were CRC dietitians. There we go. And the average years working in CF for this group was 4.78 years, and there was a standard deviation of about 5. So the chart on the left shows that prior to outreach, 52% of the CRCs had worked with home spirometry in a research capacity. And the chart on the right shows that 41% of the CRCs reported having conducted 5 or more home spirometry coaching sessions in the past, and another 41% reported having no prior experience coaching home spirometry. So you can see there's a nice balance between the CRCs who had a good amount of experience with home spirometry and those who didn't. Here's some more results from the baseline survey. We have 93% reported being very or extremely satisfied with the quality of instruction provided to the CRCs by the home spirometry trainers. 83% reported being very or extremely satisfied with outreach training activities. 66% reported that it was very or extremely easy to learn how to coach home spirometry. 76% reported feeling very or extremely prepared to conduct home spirometry. Now, after the CRC had trained at least 2 participants, we sent them the post-training survey. And the smaller N is due to the fact that not all the CRCs who were trained on the outreach study actually ended up training research participants. Some were serving as backups RCs in case they were needed. So on the left, this was a select all that apply question about how the participant trainings were conducted. As you can see, there were 13 responses for in-person, 11 responses for video conference, and there was 1 for telephone call. On the right, you can see that most of the trainings took 30 minutes or less. We also asked about any technical challenges during the participant trainings. 22% of the CRCs experienced some challenges, and here are some quotes from the respondents. So one respondent said, "We had issues with the Zephyr X app. One participant couldn't get out of the waiting area. Sometimes the Zephyr X app would work great, and then the same patient would have technology issues on the next visit. Sometimes the participant couldn't hear or see me." We had another one that said there was no audio, and the participant was unable to connect the spirometer to the app for a few hours. A third said there was lag time on the Zephyr X app. We train the subjects when we screen them, and screening and spirometry training together are about an hour. And the fourth was difficulty logging on to the provider dashboard. So needed to work with my IT department to get a single sign-on. Here's some more post-training results. We had 94% of respondents felt that the participant trainings were very or extremely successful. 83% were very or extremely confident in the research subject's ability to successfully perform home spirometry. 89% of CRCs were very or extremely satisfied with the quality of the videos and in the written coach training materials and resources that were provided to them. We had 94% of the CRCs who were very or extremely confident in their own ability to successfully train and coach participants on home spirometry. So earlier I mentioned that the primary outcome for the Outreach CRC experience study was the acceptability, appropriateness, and feasibility of the outreach protocol. Specifically, the AIM is the acceptability of intervention measure, the IAM is the intervention appropriateness measure, and the FIM is the feasibility of intervention measure. Again, they're being surveyed at each of the 4 time points, so we should be able to assess any changes in perception throughout the study. Here we have the baseline data and the post-training data, which shows that in assessing the overall outreach protocol, at baseline and again after training at least 2 participants, CRCs rated it as highly acceptable, highly appropriate, and highly feasible. I'm also showing the device training at baseline, which shows similar results, of highly acceptable, highly appropriate, and highly feasible. So at baseline and at post-training, CRCs in the outreach study reported similarly high levels of satisfaction in their training to support coached home spirometry. CRCs also perceived that the outreach protocol was acceptable, feasible, and appropriate at baseline and after they trained multiple participants. And further outreach CRC surveys will evaluate the experiences with training, coaching, and implementation of the overall trial. Just wanted to give a little plug to our poster. It's number 118. You can find it in the poster hall. Please stop by and say hi tomorrow. I'll be there during the even session. And wanted to give a big thank you to the participating CRCs at all the sites, the TDN staff, and the patients and families that are enrolled in outreach.
Okay, thank you so much. I feel like these last two presentations really underscore the changing landscape of what research coordinators and studies are what research coordinators are being asked to do for their studies, and then just how studies are changing. And my question is, it's more about outreach versus the RC perceptions, but how do you envision implementing something like outreach and home visits for long-term extension studies or for long-term extensions?
That's a great question. I don't have a really good answer for you, but I know that they are also working on getting the participants' perspective in the outreach trial, and that's going to be really important too, to see how the patients, the research participants feel about doing home spirometry for clinical trials. And so there's going to be some interviews that are being conducted, and they're also actually collecting similar data, the AIM, IAM, and FIM, on the research participants' perspectives on the trial. So we should be able to get some really good information about whether or not it's feasible to conduct long-term home spirometry as a measure.
I think that will be really important also. I mean, obviously that's important, but also too, with some of the comments that were made, pros and cons to technology, right? And usually in the moment, we're really frustrated with the technology. And then once we get into it and we're able to do the visit, the technology issues kind of become part of the past and we move forward. But what are some of the strategies that teams are using to create frequently asked questions or things that people can proactively prevent some of those tech issues?
Yeah, I think just with more experience, I think they will naturally be able to figure out, if you're seeing that your IT department is blocking certain apps or certain websites, you'd be proactive when you have a study like this, where you'll get in touch with your IT department early, make sure that everything is operating smoothly. And I think just as you get more comfortable doing these sorts of studies where you're utilizing the technology, I think it's it's natural that you'll hopefully have less issues. We actually did, I didn't present on this data, but we did ask at the baseline survey about technology use and comfort. So it looked like, for the most part, all of the RCs were fairly comfortable with the technology. So I think that helps, which is why, I think there are only maybe 4 RCs that talked about challenges that they had experienced with the technology. So.
Okay, we do have one question in here. Will there be any other future studies like the outreach study?
I don't know. That's I worked on the research coordinator portion of it. I think that's probably a question better suited for Jill or one of the TDN members. But
stay tuned.
Yeah.
All right, that is our only question on here. Anybody have any questions? Okay, thank you so much.
All right, thank you.
have the pleasure of introducing Sam Johnson next, who I work with at National Jewish Health in Denver. She is a clinical research coordinator at our site, joining our team in 2022, after graduating from the University of Minnesota with a Bachelor's of Science in Neuroscience, also with some experience in regulatory at her previous position. She's currently pursuing a Master of Science in Pharmaceutical Sciences with an intended specialty track of clinical pharmacokinetics and pharmacodynamics at UC Anschutz in Colorado. She's serving on the NACFC Program Planning Committee for RCs and is an apprentice in the RC Mentoring Program. I am always impressed with Sam's ability to think critically through a protocol and vision study visits and ask good questions. And she's going to discuss our attempts at making our research meetings more relevant and engaging to our meeting attendees.
All right, hi everybody, thank you. That was very nice of you, Alex. She added a lot more for me than I wrote about myself. I appreciate everyone sticking around, and this is fostering provider engagement through effective meeting strategies. I don't have any disclosures. So just a little bit of a background if you don't know about our team. We're a fairly large site in Denver for the adult team. So we have a clinical team. They do the patient day-to-day visits. And then I live over in what I'll call the CRS team, or Agenda A. That'll make more sense as we go on. We do a lot of those observational studies, the FDA drug studies, those things. Then we have the NIC lab, or Agenda B. They do more of the wet lab kind of science studies, things like that. We have providers that overlap in different regions, some that do all of it, and some that are just clinical. So that's where we're coming from. So we have this bi-weekly meeting, and that is twice a month bi-weekly, not twice a week. And it started in 2009 at our site. And its goal was to integrate research and care teams and get providers understanding what research we had and some of that inclusion-exclusion, and to hold some discussions about potential participants that could participate in that research. And that went along and was really great until 2019, when everything happened and our meetings moved virtual. It became a lot more difficult to connect. Between 2019 and 2023, this project, our site conducted a QI, Culture of Research project, to see when providers were talking to participants and patients about research. So that's kind of where this spun off of, and some of this results here that you can see is from that QI, Culture of Research project, that we see that our providers talk to their patients when they think there is a study for their patient, or when they know that there is a study for their patient. So we thought, how do we facilitate that a little bit better? And that came to this meeting. And the aim of this was to make the meeting more effective and relevant for all of those people that were participating. Some of the ways that we're going to do that is we were going to change the meeting format. We wanted to make it easier to follow from the meeting we had previously, kind of formatted a little bit more for the online format that we had. And then we were going to survey the RCs and the PIs that attend this meeting to see their opinions on the format change. We did this at the 3-month and the 6-month time point, and I will say the 3-month time point looks back at the old format because we did not collect data prior to the change. And then we just asked about relevancy. We wanted to see if people who were invited to the meeting, if it was even relevant to them anymore, since it had been going on for so long. So just to start, this is what we'll call the old format. This was a Microsoft Word document. It had all of the studies that were open and enrolling, not enrolling, closed, upcoming. It was about 8 to 10 pages of studies. As you can see, the study is that one little section. It has the big inclusion, exclusion. It lists the PI, the RC, all the enrollment, and then some of the discussion items and action items. This is a lot of the time was spent during the meeting in those 2 columns, the discussion items and action items. It was from this point that we wanted to change, and we were hearing that people weren't really engaged in the meeting. We weren't having a lot of conversations. It was hard to follow. So the RCs met and kind of came up with a new idea. How were we going to switch? And we came up with this format. This is a PowerPoint. It is 1 study per slide. it captures all of that same information that Word document did, but it's just more spread out, easier to follow. It now has study visit number, so when providers are talking to patients, they have a little bit more of an understanding of the ask we're getting at for a study. Just a little bit easier to see. So now we come to the survey part. We did this for 3 months. That was about 5 or 6 meetings. And then we also sent out an email to everybody that was on the calendar invite and asked them if they still wanted to be included, if it was still relevant to them. So our survey asked these 3 things. The first one was, how is their ability to follow the information being presented? It was listed from very difficult, difficult, not difficult but not easy, easy, and very easy. Then we asked how engaged were they in the meeting, from not at all, a little, moderately, to very engaged. And then we also added several comment sections so that they could put in their opinions on the changes that were being made, add in suggestions, and provide some rationale so we could see why things were changing. So at that 3-month, this is looking back at the old format, so our Word document format. What were people saying? And I will say, before we look at all of this, these numbers very much so represent all of the feelings we were feeling, just in graphs. So we were difficult to follow. As we can see here, we had 11 people respond about this. 9% and very difficult to follow, 27% difficult to follow, and then 36% somewhere in that. It's not really easy, but it's not difficult to follow information. On the engagement level, we were a little engaging. I was happy to see that we were not at all engaging, so people were there and understanding, but still not what we would like to see. After we made the changes at the same time, we asked them, how about the new format, the PowerPoint format? What are we thinking? So now we have very easy and easy to follow. It's 5 and 6 respondents here. This was we were really excited to see this change here. And then we were also more engaging. We changed, we're not a little bit engaging at all. We are moderately engaged or very engaged. That's 2 people responding to very engaged and the 9 and moderately engaging. When we look at our results from asking about attendance, that first initial calendar invite had 30 people on that invite that we asked, do you still want to be included? Is this relevant to you? We were getting an average attendance rate of about 38% of people. And then after we asked, 17 people still said yes, we would like to be included, and the rest said no, thank you. So that was 13 people that it was not relevant to. And now we have an average rate of about 53%. A lot of this is affected by the summertime, ATS, traveling, all of those things. And then this is the feedback from the PIs mainly, the comments that we were receiving. So the first big group of it was about face-to-face meetings. People wanted to see people in a room together instead of just virtual, getting together, even if it was quarterly or once in a while, which was feedback I don't think we expected. And then the next big group was asking PIs about their concerns with putting people in studies and then breaking up the meeting a little bit more with conversations and having sections of, we're going to have a discussion now instead of waiting all till the end. And then the last one would to see a list of studies with a short study description, since we kind of get into our terminology a lot with a lot of numbers and official study titles that can be confusing. So this was our round 2 between 3 months and 6 months. This addressed to that study list part. We added this slide that is sectioned off by type of study, and it has big inclusion criteria and who the provider can notify if they have somebody that meets that. This slide is first, or like third slide. Before we get into any of the other information, they can just come here and see this first. We also added a pause, just a little slide as a reminder to have some conversation in the middle. So this is after all of our enrolling trials have been talked about. We add this slide and we list them out. This is mostly the studies that are difficult to enroll for, and just having conversations then in the moment about what PIs are thinking, their questions, anything like that. We're going to survey them again at the 6 months time point, which we did. This is a reminder of the questions we asked and the scale, which we asked at. So that 6-month format, we find that we are easier now to follow, with 6 people responding very easy and 5 people responding easy to follow. We did not decrease in ability to follow that information. And then we were a little less engaging in this, but still the majority of people in that moderately engaged or very engaging. And we did increase in very engaging. So 1 person went back down to a little engaged, and then 2 more people in very engaged. So the conclusions for this were that we needed to get out of the weeds in the detail to really address the people that were at the meeting to make sure that it was right for them and the information we were sharing. And standardizing the language around studies helped a lot so that people felt like they could follow the information that was being presented. And overall, that we were able to increase our engagement with a shift of meeting format. Our next steps would be to continue taking input about our meetings. We'll continue to keep asking and changing and updating as new research coordinators come on, new types of studies, things like that. And then we would like to track how potential participants or even people that do enroll into studies are learning about research to see if this is having an effect on providers talking to their patients. And then, as always, we would love to continue growing our culture of research at our site. It's very important, especially as we enter all of these very complicated trials. I would like to give a huge thank you to everybody at the Colorado Adult CF program, especially these people up on the screen. They make our day-to-day possible. My team over here, Alex, and then Megan, who put together all of the graphs and kept me on actually getting the presentation done. She helped a lot with the poster as well. It's number 676 if anyone wants to come see us tomorrow. She was a huge help. All right.
Thank you. I just have a quick question. I'm from a small center, so this whole like big center thing is interesting to me. So on the recruiting or enrolling studies slide, from what I read, you say you tell the PIs to contact you if they have an eligible patient. You guys don't look for eligible, like how does that work?
So we'll look for our eligible patients,
Okay.
but then studies that are open for a long time, or since we have so many patients, and especially ones that travel from out of state, sometimes the providers will know a specific issue somebody's having quicker than we will.
So it's really a list down in clinic. So if a potential participant mentions to a nurse, a dietitian, whomever, then the clinical team member knows who the lead RC is to contact directly, or a backup as well. I feel biased if I ask questions, so I'm not going to ask questions. And plus I already know. Does anybody have any questions out in the audience?
I'll just guess another question. Do your research coordinators meet outside of these meetings, like the different hubs like get together too?
Yeah, the research coordinators have a huddle every week. It's on Monday. That is just the RCs from both of those teams.
Part of the reason for that too, at both of the meetings, is to make sure we're not co-enrolling people into studies that should not be co-enrolling.
Thank you.
Thank you. Thank you.
I may have missed this, so if you stated this already, I apologize, but you said your numbers of responses was 11 for a lot of them. Do you have the percentage of response rate, and did you poll your RCs, or did you poll the people outside of the RCs, like the clinic?
It's both the RCs and the PIs that attend this meeting, that attend the Wednesday biweekly meeting. So it's a mix of both.
Oh, go ahead. I can repeat it for you.
Of the 38 people that were initially invited, did that include clinical team members as well, or sub-investigators, or who were the rest of those that didn't say, this is not helpful, I don't want to
Yep. The question is, of the 38 people who were originally on the biweekly research meeting invite list, who were the people that were invited? Was it clinicians and researchers? And that's your question. Yes.
Yes, to all of that. It was a mix of everybody. We had some grants people. We had some researchers that do the like epithelial cells and like our bench researchers more, and then some clinicians and people like that. And I use PIs to clarify. Some of the doctors that are on the meeting are sub-Is on our studies. I should have clarified.
Okay. Yes. That's okay.
But so a bunch of people declined. Were there people that you really wish were coming to the meeting that declined to attend? That people that you think should be there to be
Yeah. So the question is, of those that declined, were some of those people that we feel should be at the meetings or that we would really wish were at the meetings?
Yes, always. There are people as sub-Is and even doctors that aren't on research that we would love if they would come so they could know what to talk to their patients about. I don't think specifically anybody that declined surprised us in their declining because they didn't attend regularly, but yes, there are people that I wish would come to it.
Hi. Sorry, I had to walk. So, were those meetings enough for you to conduct the research, or did you have more meetings? How do you avoid having too many meetings or not enough meetings?
It's a great question. I think that's one of the things that we've done with the culture of research too, is trying to figure out what is enough meetings. So along with the huddle that we mentioned, we also have a weekly clinic meeting, which is everybody, clinical team, our team, to talk about who's coming in. And then this meeting, I think it's a good balance right now, but it has taken a lot of time and input to figure out what's needed, where, and who should be involved. I think it's really dependent on how big your site is and how many people you're seeing.
Thank you.
Don't attend, do they still have access to those summaries that you created and things to review during the meeting?
Yeah, the meeting.
I'm going to repeat the question.
Oh, sorry.
For those who don't have access to the meetings, do they still have summaries of what the studies are and who to contact?
Yes. Yes, we keep all of the meetings that happen, each of them saved in their own like dated form in a shared drive, so anybody could go in and look at that if they wanted to.
Yes, Lisa.
What type of drive do you use to share that? Teams or something just internally?
And the question was, what type of drive do we use? Is it Teams or is it internal?
It's a shared just computer drive, just like an M drive or an I drive set up by the institution.
Yeah, it's a network drive. Great, thank you, Sam. And I will just close us out here really quick. And want to underscore too that Laura and I chose this pretty wide variety of topics for this session to underscore the importance of people submitting an abstract because it's interesting to you and your team, and it's something that y'all are doing that we could all benefit from. So even if it's not exactly quality improvement, that's okay. We as those that are reviewing the abstracts want some variety and want to see all of you up here someday. So please submit those abstracts. And these are the poster numbers. Please go by and talk to the presenters and show them some love. And thank you so much for being here, and have a good conference.
And we look forward to seeing all your posters next year.